So we'll wait for another 3 5 minutes. Just we wait. And now the technical team will upload it live on the YouTube and Facebook.
Okay.
Till connected, they will upload it live.
Okay.
And then our Stalin will invite you, and after that you can take over.
Okay, thank you. The speaker can't see herself, no?
Yeah, but there is a speaker view, but we are able to see you.
Oh, I can't see. I can't see myself.
मैडम इसका पूरा रिकॉर्डिंग आ जाएगा, आपको हम शेयर कर देंगे मैडम।
नहीं, वो बात नहीं है, मतलब देख के बोलना अच्छा लगता है।
But as an audience, we were all able to see you and your slide both, madam.
Yes.
As an audience, we are able to see you as well as the slide. Both we are able to see. My colleague is able to see. But only thing is, I don't know, you are not able to see.
No. Whenever I speak, I am not able to see myself, and nobody can see themselves.
Correct.
This is the problem, because we have taken the whole screen. If we speak on the short screen, then I can see myself.
Correct.
That is the reason.
Once this is over, then I will share with you the number of people who have attended, their responses, all those things. We will chat.
Yes. No problem.
And Mr. Satish Kumar, who has joined, he is our head, madam, sales and marketing.
Acha.
Hello, madam.
Hello.
Nice to see you, and thanks for accepting that for the webinar today. And going forward, we'll associate very strongly.
Okay.
Yeah.
My pleasure.
Yeah, thank you.
Madam, with your permission, I'm starting the webinar today, ma'am.
Okay. I'm ready. No problem.
Yeah. So, very good evening, doctors. I'm Dr. Stalin on behalf of Shield Healthcare, welcoming you all for today's scientific webinar. The topic for today's webinar is menopause and non-hormonal treatment. I kindly request the participants to post their queries in the comment box, so that at the end of the presentation, we'll be having a short QA session with the presenter. And now it's time to introduce our eminent speaker for this evening, Dr. Suman Sinha. Madam is an OG consultant at AHIVF Center and Amro Hospital and Research Center, Ranchi. Madam was a convener in Medical Disorders in Pregnancy, FOXY 2019 and 2021. And Madam is the Vice President of Association of Obs and Gynecology Society of Bihar and Jharkhand. Madam is the Vice President of Society of Vaginal Surgeons of India for Bihar and Jharkhand chapter. Madam has published many articles in national and international journals. Madam is an invited faculty in many national and international conferences. So with this introduction, I welcome you, ma'am. Ma'am, over to you, ma'am. Now you can start your presentation.
Okay, thank you, sir, for your nice introduction. Good evening, everybody. I am Dr. Suman Sinha, and very warm welcome and my regards to all my seniors, my colleagues and friends who have joined today for this clinical update on menopause. And thank you, Shield, for giving me this wonderful opportunity. And it is because of you I am here. Coming back to my topic, it is menopause, the non-hormonal and non-estrogenic treatment options. So a word about menopause. Menopause, as we all know, is defined as the cessation of ovarian function resulting in permanent amenorrhea. It takes nearly 12 months of amenorrhea to confirm that menopause has set in. And climacteric, it is, we all know, The phase of waning ovarian activity, which begins 2 to 3 years before menopause and continue 2 to 5 years after it. Thus, it is a phase of adjustment between the active and inactive ovarian function. So a word about pathophysiology. How does it take place? How menopause sets in? It is during climacteric. What happens? The ovarian function starts declining. Ovulation fails, no corpus luteum forms, and also thus there is no progesterone secretion by the ovary. Therefore, premenopausal cycles are often anovulatory and irregular. Later, ovarian follicles also fail to develop. Estrogenic activity is reduced markedly, and endometrial atrophy leads to amenorrhea. This causes rebound increase in the secretion of LH and FSH from the pituitary gland. This is about the whole pathophysiology of menopause. So this is a very irony in this slide. You can see that when we had periods, we were very upset about it, but there were no wrinkles. Again, now we are happy that there is no period, but one thing is to be upset, that is about the wrinkles. The wrinkling starts in the skin, which no woman likes. So looking at the menopause prevalence in India, due to increasing longevity, a large proportion of women spend their lives in menopause, and majority may be suffering from its consequences. But it's very sad that only 5% of them get treated. And you'll be surprised to know that 730 lakhs women in India live in menopausal age. This is a very informative slide about United States population. It has been seen that United States population of older aged persons are increasing every year. You can see that in 1950, the population was less than 20 million. It was around 10 to 15 million only. And now in 2018, the population of older generation has risen to 40 millions. And it is predicted that in another 10 to 20 years, the population of older generation will be around 65 to 84 million. That is too high. So we have to do something about it, how they will manage their life in menopause. Now, this is the role of estrogen in the reproductive organs. It is estrogen-friendly role. So, in the breast, it helps in the healthy development of breast tissues. In the uterus, it helps to repair the endometrium and prepare the uterus for fetal development. In the urogenital organ, it helps to maintain a lubricated vagina and also maintains the integrity of urethral epithelium. Now, the non-reproductive organs, the role of estrogen is in the brain, it helps to maintain psychological well-being. In the heart, it regulates cholesterol metabolism and maintains the right ratio of LDL and HDL. Its vasomotor functions are, it regulates normal temperature and perspiration. On liver, it helps to regulate fat metabolism and distribution of fat. In the bone, it helps to maintain the BMD, that is bone mineral density. And in the skin, it helps in collagen synthesis and maintain skin integrity, so there will be no wrinkling. So the total estrogen, what is in the serum of it, 30 to 40% are utilized for non-reproductive functions, that is in the brain, heart, liver, and bone, and the rest 60 to 70% are utilized for the reproductive function by the breast and uterus. So as the menopause sets in, there is tendency of progesterone and estrogen to get declined, decrease, and the FSH rises. So this is a very satirical slide. Here you can see a woman has approached to a doctor for her menopausal symptoms, and doctor is trying to explain her that this is your new normal and you have to live with that. But because your hormones are now out of balance. But this should not be our answer. We have to do something for this suffering lady. So let us see what we are going to do in the coming slides. So let us understand about the ovary function. One of the most curious features of ovary is the tendency of sex cells to degenerate. The fetal ovary contains 7 million primordial follicles, which at birth is reduced to 2 million follicles. And gradually at puberty, it is dramatically reduced to only 400,000 follicles. And this tendency does not stop here. It goes on degenerating and continues throughout childhood and the childbearing period. And the result is that no ovum can be detected in the ovary of women who has passed the menopause. So this is a very beautiful slide showing the dynamics of perimenopause. See, you can see here that the ovarian reserve of the follicles is gradually declining, and best reserve of follicles is seen at the age of 38 years. It means that at this time C is very fertile and the estrogen level is at its peak. But as she advances in her age, at 50 years, you see that the ovarian reserve of the follicles has come down to 1,000 follicles only. And when it is less than 1,000, the menopausal symptoms begins. At the same time, you see that the FSH started rising and the estradiol and progesterone is coming to the baseline. So now we have understood that when there will be follicular depletion, there will be estrogen depletion also. So they are directly proportional. Follicular depletion will directly cause estrogen depletion. There are two causes. One we all know, that is physiological. It is a gradual phenomenon, and other is by us, by the surgically removal of uterus by hysterectomy. With or without ovaries, this I want to concentrate over here, where even when you retain the ovary, there is estrogen depletion. Why? Because due to disruption of ovarian blood supply from the uterine side. Another very important possible cause is that, uterus itself regulates pituitary FSH and pituitary FSH secretion. And when there will be no uterus, this will affect the follicular development and then no estrogen. So you keep ovary or don't keep ovary, gradually there will be a depletion of estrogen level even in the younger age if hysterectomy is done. This is another slide telling, showing about the level of estrogen concentration, which changes throughout the women's life from menarche to menopause. At the time of first menstruation, which is usually 12 years, where we can see the level of estrogen in the serum is around 100 picogram per ml, and it gradually increases, and at the age of 28 years, you see that it is at its peak between 150 to 100 picogram per ml. But after that it starts declining, and at the age of 50, you see that the level comes down between 5 to 15 picogram per ml only. So what will happen when there will be depletion of estrogen hormone? It will lead to Cooperman index, which consists of vaginal dryness, hot flushes and night sweats, paresthesia, insomnia, nervousness, melancholia, dizziness, fatigue, arthritic pain, formication, palpitation and headache. So what to do? So this night flashes are in the grouped as vasomotor symptoms. As many as 75 to 80% of peri or postmenopausal women in USA reports of hot flushes. It is even severe in 10 to 15% of women. Highest occurrence occurs during the perimenopause age, that is first 2 years before the menopause sets in, and it lasts for 5 to 7 years and gradually declines. So what is hot flushes? It affects 75% of women. Intense heat is experienced in the face, forehead, neck, chest, and earlobe. It is associated also with night sweats, irritability, lethargy, insomnia, and tiredness. It is more pronounced in premature and surgically induced menopause. What are they actually? They are waves of vasodilatation caused by noradrenaline, which disturbs the thermoregulatory system. Estrogen deficiency reduces hypothalamic endorphins, which release more norepinephrine and serotonin. This leads to inappropriate heat loss mechanism. Another very important effect of low estrogen or absent estrogen is vulvovaginal atrophy. As there is decline in estrogen hormone levels in the serum, you see that the well-estronized vaginal epithelium is so thick, whereas low estrogen vaginal epithelium has become thin. That will lead to vaginal dryness, and ultimately it will cause dyspareunia and decreased libido. It also causes mood swings. Some women have mood swings, and others may have, they become very aggressive. The other psychological changes in menopause are due to estrogen depletion are insomnia, depression, anxiety, fatigue, irritability, memory loss, and problems to concentrate. So we should understand what is upregulation of estrogen. Upregulation of estrogen is actually increasing estrogen and progesterone receptors. So in menopause, if we give estrogen, it will cause upregulation in the breast and the uterus tissues. What will do that? This increased estrogen will lead to estrogen-stimulated mitogenesis of carcinogenic MCF7 cells, and that will lead to proliferation of the breast tissue and endometrial tissue, resulting in breast cancer and endometrial cancer, which is not acceptable. Other long-term complications of menopause are stroke due to upregulation, cardiovascular disease, and osteoporosis. This is due to downregulation of estrogen. Now, what does osteoporosis do? When there will be osteoporosis, this will lead to increased incidence of fracture. At 60 years, the incidence of fracture is only 25%, but gradually at 70 years, it becomes almost 50%. So you have to be very, very careful. We have to think something about it, how to prevent this osteoporosis. Here, I'm going to talk to you regarding bone health and menopause. Bone health means bone pain and the risk of fracture. Here in this slide, you can see that as the age advances, there is depletion of estrogen, and that will what do? That will impair the absorption of calcium and vitamin D. And at the same time, it will increase the osteoclastic activity and the alkaline phosphatase. Though these will increase, and that will cause decrease in the bone mineral density. There is one question: can calcium and vitamin D supplementation during menopause alone, is it enough to improve bone health? Absolutely no, because estrogen is very important for their absorption. So you have to give some form of estrogen during menopause to increase the absorption of calcium and vitamin D to increase the BMD. So what are the treatment options? Hormonal, anti-osteoporotics, and a third option is non-hormonal, that is by estrogen regulator. So the hormonal are the HRTs, we call it HRT or HT, that is hormone therapy. They are in the form of estrogen, conjugated equine estrogen, or 17-beta estradiol. The anti-osteoporotics are many: calcium, vitamin D3, raloxifene, soy isoflavones, bisphosphonate, alendronate, and risedronate. And the non-hormonal estrogen regulator is available in the form of estrogen 100. This is the HRT I've already discussed in the form of 17-beta-estradiol and conjugated equine estrogen. Conjugated equine estrogen is available as oral and topical, whereas 17-beta-estradiol is available as estradiol hemihydrate, estriol, and estradiol valerate. Now, what is the National American Menopausal Society recommendation regarding HRT? It recommends that lowest dose of HRT should be used, and that too for a very short duration, only to manage the menopausal symptom. And it should not be prescribed for chronic disease prevention because it has the potential of habit forming, and that is all. And this is for not safe for when given for a longer duration. WHI, that is Women Health Initiative, did a trial between 1993 to 2005 regarding the use of this HRT. It selected 16,600 postmenopausal women by giving estrogen plus progesterone combined, and another group consisting of 10,739 postmenopausal women, it gave only estrogen, and then they were studied. It was seen the estrogen alone trial had to be stopped because it causes increase in the risk of a stroke. And this even this estrogen and progesterone combined group was associated with increased incidence of breast carcinoma, cardiovascular disease. So both the both the type of trial was not good enough, because they did more harm than the benefit. Then again it was thought, then what to do? What to do? Can we do something about it? Can we replace this estrogen? Maybe it is a very strong estrogen. Can we replace it by a weak estrogen? Then what happened? Trial went on. Another post WHI, another trial was done with the soy isoflavones, thinking to be because it is a weaker estrogen supplement, and trial started in Korea, Japan, and China. Women of Korea, Japan, and China took high isoflavones daily as a soybean diet, in tofu, as bean sprouts, but nothing helped them. They still continue to suffer from menopausal syndrome. So it is very difficult to take isoflavones as an alternative to HRT. A recent Cochrane database review of phytoestrogens, red clover, dietary soy, and soy extracts, no conclusive evidence of improvement in menopausal symptoms in 43 randomized trials were seen. A meta-analysis of black cohorts reported insufficient evidence to support the use of black cohorts for menopausal symptoms. So it did not work. Even phytoestrogens did not work. So another study was, a very important study was done from July 2004 to March 31, 2009 for 5 years, where 45 to 60 years aged women were selected for study, and their bone mineral density, they were for 5 years in menopause, and their T-score, that is BMD, T-score was minus 2.0 in the spine, femur neck, and also in the hip bone. And they were given 200 milligram of isoflavones daily, and another group of the same aged women were given placebo, and then for 2 years they were given isoflavones, and after 2 years a study was done. It was seen that after 2 years there was no significant difference found in the participants receiving soy tablets and those receiving placebo. So apart from that, isoflavones even did not help in increasing the BMD. So we have to think something else. So the ideal menopause should have should regulate endogenous estrogen to reproductive organs and reproductive organs. It should regulate endogenous estrogen to non-reproductive organs and to reproductive organs as well. This should be the ideal drug. So the root cause, we all know, it is estrogen depletion in the reproductive organs. Option 1, we already have seen it, that is HRT, strong estrogen, and option 2 we all know now, it is isoflavones, so soy isoflavones. And now the third option, which recently we are having, is non-estrogen regulator. So ideal menopause should have upregulation of estrogen receptors for the non-reproductive organs, where there should be a significant increase of estrogen action, and it should have downregulation of estrogen receptors for the reproductive organs like breast and endometrium. So there should not be any estrogenic effect of the on these reproductive organs. So external, so it should offer this ideal drug for treatment of menopausal symptoms should offer symptom relief as good as estrogen replacement therapy without risk of cancer, venous thromboembolism, and stroke, which is associated with HRT. So current treatment options we have HRT and isoflavones. We already know what are they. So our treatment aim should be upregulation of estrogen receptors in the non-reproductive organs and downregulation of estrogen receptors in the reproductive organs, breast and endometrium, and not to replace strong estrogen to weak estrogen. So estrogen regulator, that is estrogen 100, regulates endogenous estrogen. It is given, estrogen 100 is given as 1 tablet twice daily for 3 months. It regulates estrogen affinity to estrogen receptors in the non-reproductive organs, so that the vasoendothelium reduces hot flashes and night sweats. In the CNS, it improves mood swings and insomnia. In the bone, it improves BMD, and it downregulates estrogen affinity to estrogen receptors in reproductive target organs. There is no proliferation of MCF7 cells, and therefore there is no risk of cancer. It consists of the study of age-old oriental phytochemicals led to discovery of estrogen 100, a non-estrogenic hormone regulator. It consists of cinnamic acid, 45 milligram, S-methyl ester, 41.78 milligram, and dicursine and dicursinol angelate 45 milligram. So estrogen 100 is non-estrogenic hormone regulator. It has no effect on estrogen receptor alpha and beta, and it inhibits the cancer cells, which is known as MCF7 cells. Now, evidences. Studies were conducted in USA, Korea, and published in renowned journals, in Journal of Korea Society of Menopause and Phytotherapy, USA Journal in 2011. And the evidences were seen that when it was given only for 7 to 14 days, the symptoms of vaginal dryness, hot flushes, mood swings, bone pain, there was dramatic relief in these symptoms. So the study concluded that subjects who were on estrogen 100 had a significant reduction of 10 out of 12 Cooperman index, which is very good. Cooperman index symptoms. So when we give this drug for a long time, we can see that there is decrease in MCF7 cells and cancer risk is decreased that way. The CVD and stroke risk is also decreased. LDL and triglycerides level is decreased, and the good lipid, that is high density lipoprotein, it has been seen that there is increase in the level of HDL. There is no increase in estrogen receptor alpha and beta. There is no increase in serum estrogen in the reproductive organs. There is no increase in serum FSH. There is no increase in human growth hormone. which is very convincing. Even the osteoclastic activity is decreased when it is given, and the alkaline phosphatase level is also decreased, so that there will be increase in the bone mineral density. So in one study, it was seen that before giving Estro-G, the level of the bone mineral density was 0.746. And after 1 year of treatment, the level increased to 0.763. So it is a significant increase. Now, in Korea also, study was being done to know the effect of this herbal extract Estro-G 100 in the pre, peri, and postmenopausal women. A randomized double-blind study was done in Samsung Chill Hospital, Korea. And the conclusion drawn was a 12-week treatment with Estro-G 100 showed a statistically significant improvement in the various menopausal symptoms such as hot flash, night sweats, paresthesia, insomnia, nervousness, melancholia, vertigo, fatigue, rheumatic pain, and vaginal dryness compared with the placebo group. There was also no adverse effect reported with Estro-G 100. There were no significant changes in body weight, BMI, serum estrogen levels, serum FSH levels, or even liver enzymes, all of which have previously been observed with hormone replacement therapy. In this clinical trial, Estro-G 100 appears to be an effective and safe dietary supplement for use in pre, peri, and postmenopausal women. It is also ideal for surgically induced menopause, hysterectomy with or without oophorectomy. Evidence of non-estrogenic hormone. The effect of herbal extract Estro-G 100 on pre, peri, and postmenopausal women, a randomized double-blind study, placebo-controlled study was done in USA. That was in Korea, and this is in USA, 2012. The study was done in 2012. In this study, the mean serum estrogen levels in the Estro-G 100 group did not increase, implying that Estro-G 100 is not an active estrogenic compound, and the mean serum FSH levels also remain unchanged. Study findings so that there is significant improvement from hot flush, vaginal dryness, mood swings. It is a very busy slide, so I'm not going. I've just read the answer. Evaluation of effectiveness and safety of Estro-G 100 on perimenopausal women for 1 year. This is another study from Samsung Chill Hospital, Korea. The objective was designed to investigate the effects of non-hormonal treatment of Estro-G 100 for the perimenopausal women. A prospective randomized clinical trial was performed. A total 48 perimenopausal women were included in this study and divided either into Estro-G 100 group and a placebo group. 24 were in the Estro-G 100 group and another 24 were in the placebo group. The treatment group was treated for 12 months with oral administration of 2 capsules of Estro-G 100 twice daily, and then the bone mass density, serum bone markers, weight, BMI, serum lipid profile, human growth hormone, FSH, and ET were measured at baseline at 3 months, 6 months, 9 months, and 12 months. Final analysis was conducted for 42 subjects who were medicated continuously for 12 months. Conclusion drawn was perimenopausal women may have benefit from Estro-G, a supplement especially for climacteric symptoms, fever, neck, BMD, serum triglyceride, and human growth hormone without weight gain or any serious side effects. No toxicity was found even at 2 gram per kg body weight. It was given at this high dose also, there is no toxicity even. How it was known? It was by experimenting this high dose on the rats And the mortality, general symptoms, body weight changes, and necropsy findings were observed. No mortality was observed, and no specific abnormal symptoms were observed in them, except there was some compound colored diarrhea on the day of administration. That is not a very serious side effect. And now this Estrogen 100, 1 tablet BID is concluded to be the #1 hormone replacement drug for treatment of menopausal symptoms, and it has been approved and accredited in major developed countries, in majority of developed countries like USA, Canada, Europe, and Asia. So we have, our goal is now set to free our women from being hurt of the menopausal symptoms, which give them a drug that is safe, effective, and non-estrogenic. Thank you very much for your patient listening. Thank you once again.
Thank you, ma'am. Thank you for your wonderful presentation, ma'am. From your presentation, we can be able to understand that postmenopausal women really need some special care and attention, ma'am.
Yes.
So it's always a honor hearing you, ma'am. Ma'am, I will read out the questions, if any, in the comment box.
Yes.
Let me wait for 2 to 3 minutes for the participants to post their queries, ma'am.
Okay. Okay.
Madam, when we are speaking about this non-hormonal treatment, what will be the role of vitamin E, ma'am? Vitamin E in this treating menopausal, postmenopausal symptoms, ma'am.
Vitamin E, when you give this Estrogen 100, I don't think it is necessary to give vitamin E.
Okay.
You have to supplement with calcium and vitamin D, because they are this estrogen, even if it is non-hormonal, it increases the absorption of calcium and vitamin D. It is not that only if you give Estrogen 100, the bone mineral density will increase. You have to take calcium and vitamin D.
Okay, ma'am.
Because it is involved, it upregulates the estrogen, right? Estrogenic activity is upregulated in the non-reproductive organs. And here in the bone, it increases the absorption of calcium, and calcium gradually increases the absorption of vitamin D3. This is the...
Okay, ma'am.
What is the cost? Actually, I didn't ask you the cost. People might like to know.
I think it is 39 rupees, ma'am, per
How much?
tablet.
One
39
tablet?
rupees. Sir, Venkat, sir, you can answer the question, sir.
40 rupees, I think, no?
Sorry?
Venkat, sir?
Yeah.
What is the cost of the tablet, sir?
39 rupees per tablet.
Yes, sir.
Achha, okay. So you have to give short term. For 3 months, you have to give.
Yeah,
it can be increased to 12 months without any adverse effect, but short term it is good.
While telling for minimum 3 months for better results.
Yes. Yeah. So Dr. Stalin was asking me that vitamin E. Actually, when you give this Estrogen 100, then you have to combine these drugs. So vitamin E, I don't think that much needed. Vitamin D and calcium, I know. Vitamin E can be given because it is good for skin and...
Yeah, ma'am. That is what I mean to tell you. Yeah.
It is good for skin.
Yes.
So ladies are very much worried about the wrinkles which starts appearing during the menopause age. So it will do good to them.
Yes.
Because even nowadays all the creams are formulated with vitamin E. So I think they will... But it is also in higher dose, or if it is given for a longer time, it is associated with side effects also. Vitamin E dose should not be more than the required.
Yes, ma'am. So, madam, I could not find any other questions in the chat box, ma'am.
Maybe
So
it
if
is
you
self-explanatory or something.
yes, ma'am. So
Because
if you allow us, then we can end the webinar for today, ma'am.
yes.
So thank you, ma'am. Thank you very much for your presence and spending your valuable time with us, ma'am.
Thank you.
On behalf of Shield Healthcare, I like to thank all the delegates for their patient listening also, ma'am. So thank you one and all. Have a
Thank
good
you.
day, ma'am.
Thank you so much.
Thank you, sir.
Thank you very much, madam.
Okay.
Thank you. And thank you very much for the audience to spare their valuable time. Listen to madam's lecture. Thank you very much.
Okay.
Starting, sir, the meeting can be ended, sir.
Yes, sir.